I am relatively new to Vanderbilt. I started here in July. It's a very interesting time to start a new job as a microbiology lab director, as you might imagine, not to mention moving across the country with my family. And so it's been really interesting. So here are my disclosures. And what we're going to talk about today is a couple of strategies to ensure our molecular test results are consistent with phenotypic susceptibility test results, some strategies to evaluate how to compare phenotypic resistance mechanisms in MIC results. And then we've all been dealing with the supply chain so much. And so we're going to talk a little bit about alternative test media and what to do when our supply chain is uncertain, which I'm sure many of you have experienced. So here, I am here at Vanderbilt now. This is our beautiful hospital. We have both an adult hospital as well as a pediatric separate standalone hospital. We're about just over 1,000 beds all told. We're a level 1 trauma center, which has been interesting for me. I've never worked at a trauma center before, and so the types of infections we see are sort of different than what I was used to at UCLA. We're also a very large burn center, and we have a big heart, kidney, and kidney transplant program. So here's our team. You can see they're all masked up for COVID, ready to go, but this is the team in our main microbiology lab. Okay, so what I thought we'd do is go through a couple of cases, and these are all real Vanderbilt cases that happened in the first couple of months. Honestly, I think probably in the first month of starting on the job. So this first case I'm calling VRE, or is it? And so it's a 75-year-old gentleman who has relapse of his AML. He's status post-stem cell transplant, and unfortunately, he develops some neutropenic fevers. He's febrile overnight to 102 Fahrenheit, and he develops ARDS. And so they start him on treatment with meropenem and azithromycin because they're concerned for him on a community-acquired pneumonia type presentation. And his blood cultures show gram-positive cocci in clusters, which is sort of interesting. And so we performed the Veregene at Vanderbilt. And so we performed our Veregene test on this. And interestingly enough, it was an Enterococcus faecium. And the Veregene said that it had Van A. So the next day, we performed susceptibility testing using our AST system, and this is what we get. So a couple of things I'll point out here. So first off, ampicillin resistance is pretty common for our Anaerobes faecium, so we didn't really bat an eye on that too much. Daptomycin results in MIC of 4, which by the current CLSI breakpoints is considered susceptible dose dependent. And the reason we call them susceptible dose dependent and not just susceptible is that for Enterococcus, the clinicians really need to up the dose of daptomycin to be able to treat an Enterococcus. And so in this case, it's actually about twice the amount of the FDA label so that you would need to use. We perform gentamicin synergy testing because this is a sterile site, which is susceptible. Our Synercid is susceptible, which is what you would expect for an Enterococcus faecium. A little side note about Synercid, also known as quinipristin dalfapristin, no longer available in the United States in most instances, and the FDA has actually taken away its indication for Enterococcus. So something we can probably start phasing out of our practice. Linezolid is susceptible. And then interestingly enough, vancomycin gives an MIC of 0.5. And so really this is the result that is very puzzling to us because our Veregene said that there was a Van A in this particular specimen. So a couple of things could happen here. This could be a susceptibility test instrument error. It could be the Veregene that screwed up, hard to say. Maybe we have 2 different organisms in the same bottle. And honestly, I was leaning that way until I went back and really scrutinized that original gram stain, which is really much more clumping enterococcal-like things. So another possibility is that maybe this isn't really an Enterococcus faecium, it's something else. Or, and we all hate to see this happen, but we know it does happen, perhaps the blood culture bottles were mixed up during our workflow. So we investigated all these different things. We carefully reviewed the purity plate. We looked at the subcultures. We looked at the Varigene results. What we found from the purity plate is, a very consistent Enterococcus-like colony. We tested that actually on the Varigene, and sure enough, this organism did have VAN-A. We repeated the susceptibility test, and again, we got a vancomycin susceptible result. And because we didn't believe it, we did a disc, and sure enough, it was susceptible by that as well. So everything we did pretty much confirmed this bizarre finding. And so what we opted to do is to edit the vancomycin result to resistant. And the reason we went this path is it is something recommended by CLSI. But I think this case kind of demonstrates all the different troubleshooting we have to do, particularly if we're using two different test methods that ultimately get to the same, sort of result. So this is a table that's in the M100 CLSI document. And if you aren't familiar with this, it's called Appendix H. It's pretty helpful. And essentially what it is a table that helps labs troubleshoot this type of result. And so you can see, if VAN-A or B is detected and it's vancomycin resistant, that's normal. If the opposite is true, not detected, vancomycin susceptible, also normal. We don't need to do anything fancy there. But then we have these cases like what we had where you detect the gene, but the phenotype is susceptible. And in this case, you confirm the identification per CLSI, which we did, repeat your susceptibility tests and check for mixtures. And at the end of the day, if you do all that and you're still no further ahead and it's repeating, what they recommend you do is report it as VRE. If the opposite happens, where VAN-A is not detected or VAN-B is not detected, but it's vancomycin resistant, in that case as well, you err on the side of caution, and CLSI recommends you to report it as a VRE. So if we dig a little deeper into this on what is going on, this is actually a really interesting phenomenon that we're starting to see more and more often. And so this is VAN-A gene, and it is present in Enterococcus, but it's what we call a vancomycin variable Enterococcus faecium. And so what happens in this case is you have a wild type VAN-A gene that's susceptible by MIC or disc for whatever reason. But the tricky thing is that the organism has been shown to convert back to that resistant phenotype if you start the patient on vancomycin therapy. So that's sort of the fancy thing that could happen. And that was, in fact, what we found to be true in this case after doing some sequencing. But other things that could happen is, VAN-A is present in a lot of non-enterococcal species like anaerobes. And so if you do have a mix in there, that could be where your VAN-A gene is coming from. And of course, mixed cultures and new genotype, all these things could also lead to that similar phenotype. So a bit more about this vancomycin variable Enterococcus. So if we remember, vancomycin resistance is kind of complicated, but essentially what happens is vancomycin targets this terminal diala of the peptidoglycan. And what can happen if you have the VAN-A gene cluster is it will modify this end of the peptidoglycan such that vancomycin can no longer bind to that alanine because it's being masked by these other peptide sequence. And so what happens in these vancomycin variable Enterococcus is that this regulator machine that turns on this VAN-A cascade is turned off for whatever reason. And because they've lost this VAN-RS, which is the regulator of this whole process, VAN-A is not turned on. And so you have VAN-A, but you have a vancomycin susceptible phenotype. The tricky thing, though, is that it can acquire that VAN-RS again or turn on this cascade by other mechanisms and become vancomycin resistant. This was really originally reported out of Canada, and these were some isolates that they had that was reported in JCM a couple of years ago. And essentially, what they found in this one gentleman who had sepsis due to Enterococcus faecium is VAN-A was present, the vancomycin MIC was susceptible, and it was missing this VAN-RS regulatory area. They started the patient on vancomycin, and very quickly, 2 days after they started therapy, that vancomycin MIC was cranked way up. And in this case, it wasn't because it reacquired that VAN-RS, but it was able to turn on this VAN-A cascade by a different mechanism, which we're still not totally sure how that works, but nonetheless. So the risk here is, if you were to call it vancomycin susceptible, is that the patient would fail therapy because the isolate becomes resistant on treatment. So a couple of kind of bottom lines from this case, I think it was confusing to us, and it really highlights how important it is to make sure your identification, your genotype, and your phenotype all match up. And the importance really of troubleshooting those discrepancies. And so if we hadn't really dug into it and we had decided to go with the MIC, that could have been problematic. And conversely, there are instances where you detect VAN-A and that's an error on the other end, in which case you would be putting a patient on alternative therapy like that daptomycin I mentioned that maybe is not as effective as Vanco could be. And so when in doubt, according to CLSI, they recommend that labs report the more resistant results in these cases for Enterococcus vancomycin. This is true also for Staph aureus and MECA, same story. And then you also want to keep an eye out for trends and escalate. And so we're keeping our eye out for these types of isolates because we are a little bit concerned. We've seen one that we might see more, and we don't do the Verigene test on every isolate. We only do it on blood isolates. And so had this isolate been from another specimen type, we probably would have missed this altogether and called it vancomycin susceptible. Okay. So another case, this was a little bit later into my start at Vanderbilt, a patient with COVID-19 secondary bacterial pneumonia, and secondary spelled wrong, sorry about that. So this is a 65-year-old guy who was diagnosed with COVID-19 in late August. He was intubated, he was on really high ventilation settings, he was under deep sedation, they paralyzed him. He completed pretty much everything you can at that time for COVID-19, dexamethasone, remdesivir. They'd also given him vancomycin and piptazo for concern of secondary bacterial infections, which is something that happens with some frequency for these patients because, it's not always clear what's going on. And so this gentleman was not doing very well. And so they transferred him to Vanderbilt at his family's request. And when he came to us, he was septic, and they did a lot of deep inline suctioning through his vent with a lot of sputum. This is what his chest x-ray looks like. And you can see a lot of consolidation on the right lung, which is really indicative or consistent with a ventilator-associated pneumonia, which is another thing that we see at some places with COVID-19, where things are a little crazy and it's hard to be 100% with your VAP preventing protocols. Thankfully, things have calmed down and we're not seeing this as much, but we certainly did see some of it earlier and kind of in the middle of the pandemic. Anyhow, so his respiratory cultures grew Kleb pneumo, and here are the susceptibility test results. And so you can see it's a pretty resistant bug. It is resistant to all the beta-lactams with the exception of ceftazidime avibactam, which we test routinely on our panel. We use the BD Phoenix, as well as meropenem vaporbactam, which we test routinely. It's on our panel, and it was susceptible to that. And so an interesting thing about this test panel is it has this cool feature called the Cpo Detect, which is a carbapenemase detection kind of algorithm. And this spat out a result that said this organism has a class B beta-lactamase. So like I said, the Cpo Detect, it's part of the panel. We were really excited when we got it because we were able to discontinue our MSIM tests, which are texts, it's kind of a pain in the butt to run. It does this carbapenemase detection for Enterobacterales, Pseudomonas aeruginosa, and Acinetobacter baumannii. And if it happens to be an Enterobacterales, it'll confirm the class as class A, which would be like KPC, class B, which is your metallo-beta-lactamases like NDM, Impervim, or class D, which is like your OXA48 likes. So when we were reviewing these results, this was all very good, except for there was one thing, actually two things on this report that really did not make sense to us, given this class B beta-lactamase detection. And that's the ceftazidime avibactam result and this meropenem vaborbactam result. And the reason these don't make sense is that avibactam and vaborbactam do not have activity against class B beta-lactamases. So they should be resistant if it really is a class B. And this is super important for us to figure out for this gentleman, because if it's a class B beta-lactamase, we're essentially telling the team every drug's resistant, good luck. If it's not really a class B, using ceftaz AV and meropenem vabor, one or the other, would be really the preferred therapy for this case. So the original clinical studies for the BD Cpo Detect test, it's always helpful to go back to those data when you're evaluating these types of things. And they had really beautiful data in their clinical trial. They tested, over 1,000 Enterobacterales with a positive % agreement of 98.5, negative of 97. And for those Enterobacterales, it was right, more than 95% or 95% of the time with the right class call. One thing I would point out about these types of studies, though, is that it really, and we actually participated in this study. It was right when I was leaving UCLA, and you can see Janet is an author on it. The studies tend to be enriched for isolates that have a carbapenemase. And so these positive predictive values, really, it depends on the prevalence of what you see in your population. And so if you're testing every single isolate that you see in the clinical lab, like we do, you're going to get a lot of false positives because most of them are going to be negative, right? That pretest probability is low. So looking at these results, to really scrutinize it, okay, it's saying that there's a beta-lactamase, a carbapenemase present. So we would expect ertapenem and meropenem to be resistant, and sure enough, they are. The ceftaz AV and the meropenem vaborbactam, this doesn't make any sense. Again, like I mentioned, that class B should be resistant to these, and so there's definitely something goofy going on. And then interestingly, I put a kind of a question mark here beside aztreonam. And the reason that's a question mark is if an isolate only has a class B carbapenemase, then you would expect this to be susceptible. Class B beta-lactamases just don't have activity against aztreonam. However, most isolates that have a class B beta-lactamase also have an ESBL, and in that case, it would be resistant. So really, in this instance, any result is okay for aztreonam, but it is interesting to note it's resistant to aztreonam. All right, so if we go back to that table in the CLSI M100, there is guidance for the Enterobacterales, and they talk about different resistance mechanisms. So in this case, it would be detection of any tested carbapenemase target. And this is a phenotypic test, but really it's the same thing. It's saying there's a carbapenemase here. And what the tables is saying, it should be resistant to all carbapenems, and sure enough, ours was, so nothing to be done. And this is one of the limitations of this CLSI table, and CLSI is in the process of looking to update it. But all of these new drugs that have come to market in the last 5 to 10 years, like ceftazidime avibactam, meropenem vaborbactam, imipenem relebactam, cefiderocol, all these things aren't addressed in these tables. And that's where we're seeing our problems. So when we look at these newer drugs, I think it's helpful, and I know most of us don't get a lot of opportunity to be, thankfully, testing or prescribing these, but it's good to kind of reflect on the different activities that these newer agents have across the different types of carbapenemase classes. So class A, again, being KPC, class B being like NDM, IMP, or VIM, and class D being OXA 48. Good grief. So ceftazidime avibactam has good activity against class A and class D, but it does not cover class B. Ceftolozane tazobactam, it's not really a carbapenemase producer drug. It's really more of an ESBL Pseudomonas drug. It doesn't cover any of them. Imipenem and relebactam is really designed for KPC, and it has good activity against class A's, and so against OXA 48, but again, nothing against class B's. And then meropenem vaborbactam is just a KPC drug, and so it doesn't have any activity against class B or class D's. Cefidorocol can have activity against any of them. This is why so many people are excited about this. And then aztreonam, like I mentioned, if it's a class A or a class D, it's not going to be active. It can be active, though, if it's a class B with no ESBL. So bottom line here, there's something goofy going on with our report because it's saying there's a class B carbapenemase, but that if that were true, it would be resistant to ceftazidime avibactam and meropenem vaborbactam. All right, so in this case, we want to go back to our key practices. We want to make sure our identification, genotype, and phenotypes match. We want to troubleshoot the discrepancies, so re-identify, make sure it wasn't mixed. When in doubt, report the more resistant results, and keep an eye out for these types of trends. And so we've done all of this. And the only thing I would change from that is kind of lessons from the VRE case is, it doesn't have to just be a genotype that you're comparing to, but it could also just be the general resistance mechanism. So if you're doing ESBL testing, kind of spot checking to make sure those things make sense. If you're doing a modified SIM test or using a test like this one, make sure that that resistance mechanism makes sense and jives with your phenotypic AST results. So what we did for this particular isolate is we did a modified SIM test, and that was negative, which to us said there's most likely not a carbapenemase here. We also did a PCR for the typical genes, and that was also negative. And we performed e-test for the ceftazidime avibactam, which totally confusingly was resistant. And so what we wound up doing is we edited that ceftaz AV result to resistant. And because of like this uncertainty about what was going on exactly, we agreed to investigate cefidorocol as a treatment option. And so, in this case, neither the resistance mechanism or the phenotype was correct. And this is probably just a very tricky isolate to be done. And we're working on sequencing this and with BD on this type of issue. And as part of their response to this, they've actually updated the software for this particular test so that if class B is being called, but the ceftazidime avibactam result is susceptible, it's going to overcall that class B call and not report it out. So we've actually struggled a little bit with this Cpo Detect test, and we're not the only ones that have had this challenge. And so this is a really nice study out of Italy where they looked at all of their clinical isolates kind of in routine practice testing with this. And what they found was really good sensitivity for the test, but the specificity was kind of crummy. So for the enterics, 84% specificity, for the non-fermenters as low as 43. Our problem we tend to see is with Proteus species. For whatever reason, it likes to call class B with Proteus for us. And so when we did a little audit with 25 recent isolates, and we did MSIMs and eSIMs for all of them, none of them were positive. And so we actually don't use this result for that reason. And again, I don't think that it's necessarily something horrifically wrong with the test. I think it really is just a pretest probability issue. If you're at an institution where you only get, 1 or 2 or 3 carbapenemase producers in a month or a year, you're much more likely to get these false positives. The team out of Italy had a nice kind of workflow that they proposed where they looked at that meropenem MIC. And so if the MIC was high, they would go ahead and do a Carba-NP test, or you could do an MSIM test or something like that to confirm that result. And if the MIC is below 0.12 or the lowest dilution on the panel, they would just go ahead and report it out as negative. And we've started using a protocol like this. So what we're doing right now, and I'll be honest, we're still, working our way through these challenges with the carbapenemase detection. We're checking these carbapenemase results versus the carbapenem MIC, the ceftaz AV results, and the meropenem Weber-Bactam result. If things aren't making sense, we're going to re-identify, re-perform susceptibility testing, and check our purity plates. And if carbapenemase is called, and it sort of makes sense based on the carbapenem MICs, we've actually implemented the Carba-5 test, which is available from Hardy. And that is something that's been really helpful for us to clarify these things. And in fact, just today, we had an Enterobacter with a KPC detected and confirmed by this Carba-5 test that was resistant to ceftazidime avibactam. And it was, in fact, a case of a treatment failure. And so this patient had been treated with ceftazidime avibactam. And what can happen is your KPC mutates and becomes resistant to ceftazidime avibactam. And when that happens, your meropenem MIC goes down a little bit. And so that's like kind of the hallmark. And so it was sort of interesting to see that today. If it's a class B and it's susceptible to ceftaz AV or meropenem Weber-Bactam, we're confirming those results with e-test or another offline method. So there's a lot of options for carbapenemase detection out there. I don't want to just talk about the Carba-5 and the Cpo Detect because that happens to be what we use, but there's a lot of really good options. The Carba-5, like I said, it's a lateral flow assay. It's really, really quick. I don't even think it takes 20 minutes, honestly. From a colony, it's pretty slick. You can just do it as you're working up your cultures, and it differentiates all the main carbapenemases, and it's for Enterobacterales and Pseudomonas aeruginosa. I've used the expert Carba-R test before. It's a PCR-based method, same kind of story. You can add an Acinetobacter. And then there's a bunch of other different types of methods, including ones that are endorsed by CLSI to help look for these resistance markers. And it is important to do this, in my opinion anyway, but I know it's a lot of extra effort. And so I think sometimes it's helpful to take a little step back and say, okay, like, what are we doing? Why are we doing this? And, there's pros and cons to doing carbapenemase testing on these types of isolates. So a couple of the pros is, as I've shown in these last two cases, it can be super helpful to troubleshoot your susceptibility results. And it's also of value to predict the activity of these newer antimicrobials. So if you know you have a class B carbapenemase, you know that the main ones are off the table. And it's also super duper valuable from an epidemiological perspective. We had a really big outbreak of CRE when I was at UCLA, and the only way we were able to figure out what was going on was through the fact that we did carbapenemase testing and were able to track strains based on their carbapenemase resistance mechanism. On the downside, though, we know CLSI and FDA and UCAST and all these organizations have really hammered home to us that the best predictor of clinical outcomes is that MIC result. And so knowing it has a carbapenemase or doesn't have a carbapenemase shouldn't matter. It should matter what is that MIC. Also, like I think I showed, it can be really confusing in light of all these other lab results, and it takes extra time. You've got extra QC, all these extra considerations to doing it. So you have to kind of weigh these based on your patient population and what's going on with your isolates at your facility. Okay, so moving on, this is the third case, since this is my trauma center stuff, kind of fun. So it's a 48-year-old guy who on the job had a crush injury to his hand. And so he had amputation of his small finger and his ring finger, which I think you can see there in the picture. And post-operatively, they gave him cephalexin. And unfortunately, he came back to the emergency department about a week later due to really a lot of pain in his amputated fingers and a foul odor. And I think you can see particularly with the small finger, like purulence and inflammation. And so what they wound up doing for him is they took him into surgery again, did a revision, they did a lot of irrigation and debridement, and what they found was infection of his flexor tendon sheath of that small finger, which is really not a good thing. So his results, again, it was another club pneumo, which was kind of interesting. And it was detected as an ESBL. And now my lab is savvy that I want them to be like checking all the results. And so like, well, should we trust these results? Because it's telling us there's an ESBL, but it's susceptible to all these different cephalosporins, including aztreonam, cefoxitin, cefepime, ceftazidime, but it is resistant to ceftriaxone. So like, what do we do in this case? Okay, so if you go back to that M100 appendix, again, when they talk about looking for ESBLs, so CTXM or any ESBL, really, you can get variable resistance to the third and fourth generation cephalosporins, just like we saw in that case. And this is one area that's super duper controversial right now. It has been for a while, but it's kind of coming to the forefront again, where do you edit those cephalosporins to resistant because there is an ESBL, or do you trust the MIC and report the phenotype as found? And what CLSI currently is recommending is that you report that phenotype as found. So here's the rub. There are a lot of different ESBLs. There's over 2,000 different ones described. And if you look at their activity against these different beta-lactams, and this is using 2020 breakpoints, so current breakpoints, most of them will result in ceftriaxone resistance. So if it's a SHIV or a TEM or a CMT or CTXMs, typically they'll be resistant to ceftriaxone. Ceftazidime susceptibility can happen, particularly if you have a CTXM14. Cefepime susceptibility can happen, again, particularly with that CTXM14 or with a TEM ESBL. And then piptazo susceptibility, often they're susceptible, although there are some ESBLs like this CMT, which is pretty rare, that will be resistant to piptazo. And so the bottom line here is that all these different enzymes have different activity against these different cephalosporins we might use, and it's not kind of a one size fits all for resistance across all these classes. So the reason this is so controversial these days is the Merino trial, which is a couple of years old now. But essentially, this was a study done by David Patterson and group out of Australia. And they wanted to prove that for ESBL producing isolates, you could treat a patient who had a serious infection like a bacteremia with piperacillin tazobactam. And the idea here was that you would spare the patient the carbapenem, which is a much broader therapy. And so when they did this study, it was actually a study of ceftriaxone not susceptible isolates, so not ESBL producers, but they used the ceftriaxone as that marker. And again, because typically they will be resistant. And they enrolled patients who had bacteremia, and they randomized them to either getting meropenem or piperacillin tazobactam. So if you look at the breakdown of the type of ESBLs, most of them were CTXMs. There was a smattering of other ESBLs. AMP-C can cause this phenotype. And then there were some that had both AMP-C and ESBLs, and then some had no resistance mechanism. And so what they found was not what they were hoping to find, which was that the mortality in the arm of patients that was treated with piperacillin tazobactam was significantly higher than for the patients who were treated with meropenem. And this was really shocking to them, because they had sort of set out on this stewardship endeavor to try to reduce meropenem usage. And what they actually did is prove themselves wrong, and came out with the recommendation that if it's ceftriaxone intermediate or resistant, so not susceptible, a carbapenem is preferred therapy. And there's been a lot of discussion about this study, but the majority of patients were people who had urinary tract infections with a urosepsis, so not the sickest of the sick. So this, and I know many of you have probably been asked to do this by your ID docs, should we go back to ESBL testing? So I have a couple of thoughts on this. The first thing is that Merino trial is based on ceftriaxone results, not on ESBL. And in fact, like I showed you, a lot of the isolates did not have an ESBL. And the other thing I always like to point out to people who ask about this is that, even the CLSI reference method, that double disc diffusion that we do, is not perfect. And so if you look at the positive predictive value of that test, and these are some data, relatively recent data, the positive predictive value, so the probability that there's really an ESBL if you get a positive result, is really good for E. coli and not as good for Kleb pneumo, whereas the negative predictive value is not so good for E. coli, but really good for Kleb pneumo. So, even that reference ESBL test that CLSI published is not perfect. And in fact, looking at ceftriaxone intermediate or resistant results is a more sensitive and specific gauge for an ESBL or a resistance mechanism. Plus, it's what they actually studied in this trial. So what we're doing for ESBLs is we're checking those cephalosporins against that ESBL call, or if it's on the Verigene, the CTXM result. We're kind of reinforcing and reminding ourselves that the ceftazidime can be susceptible or resistant, but we expect both ceftriaxone and the cefepime to be resistant. And if that ceftriaxone is intermediate or resistant, what we've wound up doing is suppressing the piperacillin tazobactam result, regardless of what that result is, and reporting the meropenem. Because we want to encourage people to use, kind of weirdly enough, a carbapenem in these cases because it's really the best therapy. Okay, so moving on to another case. This is another kind of COVID-related case in a way, a roundabout way. And so this is a 4-day-old baby girl who was taken to the library by her mom. They just went up for like a little walk to get out of the house. And while they were there, mom found baby in her stroller, but not breathing. And so obviously, like anyone would, she phoned the ambulance and they brought her in to Vanderbilt. And so some of the history is mom had really limited prenatal care, and she was positive for trichomonas at delivery. And the baby on exam had bilateral purulent conjunctivitis and a conjunctival lesion. This is not our baby, this is from the internet, but same story. And her chest x-ray had a lot of interstitial fluid in her lungs bilaterally. And so they started her on ampicillin and gentamicin, as well as acyclovir. And the infectious diseases team was consulted and they added on cefotaxime. So here's her x-ray, which I personally could look at little baby x-rays all day long. They're really interesting, but here it is. And really what they saw were reticulonodular opacities in both sides of the lung. Her CSF was pretty benign. Her eye discharge grew Niceria gonorrhea, and her tracheal aspirate, interestingly enough, also grew Niceria gonorrhea. And so they expanded her treatment to ceftriaxone and azithromycin. So the reason I'm saying this case is kind of sort of COVID related is we've seen a big uptick in our neonatal gonococcal infections, like really surprisingly so. And one thing we think is in part contributing to this is that people just have reduced access to care through the pandemic. And so maybe people who are a little bit less prone to go in and do all their well visits or their prenatal visits, it's more difficult for them. That threshold's so much higher and they're not doing it. And so, typically we treat babies, at least with eye drops upon birth, but in this case, that did not happen. So if we talk about resistance, because that's what this talk is about, one of the big challenges with Niceria gonorrhea is tremendous increases in resistance over time. And so these are data from the CDC, from their GISP program, which is the Gonococcal Surveillance Program. And what they do is they collect isolates from clinics who see men who have sex with men that are positive for gonorrhea. And then they do a culture and they perform susceptibility testing on them. And the reason they choose that population is resistance tends to emerge in that population first. And then they'll track these data over time. And so up until very recently, the recommendation was to give both azithromycin and ceftriaxone. And for this baby, actually, even though she was negative for chlamydia, gonorrhea, we don't typically associate with a neonatal pneumonia. Typically, that's a chlamydia trachomatis infection. And so they wanted to make sure, first off, that they covered that. Chlamydia as well with the azithromycin. But typically, up until very recently, it's been dual therapy. And part of the reason is that we're starting to see these ceftriaxone MICs creep up. Most recently, they've increased the dose that ceftriaxone is given at for uncomplicated gonococcal infections, and they've dropped the azithromycin. And the reason they've done that is you can see here, we're starting to see more and more isolates that are considered not susceptible to azithromycin. So the story for gonococcal infections is really interesting. But over time, different regimens have been recommended. So in the early 1980s, penicillins and tetracyclines were used quite a bit. Ceftriaxone was used until the fluoroquinolones came to market, and then a lot of ofloxacin and ciprofloxacin was used. But then Neisseria gonorrhea became resistant to those agents through acquiring a mutation. And so those kind of were removed as a treatment option, and now we're using cephalosporins. And for a while there, like I said, we did use azithromycin in combination. So, you know, we actually had just last week another case of gonorrhea actually in a blood culture, which is interesting, from a fellow who had a disseminated gonococcal infection. And, you know, of course, we want susceptibility data for these isolates because while empirical therapy is with ceftriaxone, because there's just too many resistant isolates out there, if you can give the patient targeted therapy, in many cases, drugs like ciprofloxacin might be an option, particularly if you're looking for something oral. The trick, though, is most of us don't do susceptibility testing anymore for gonorrhea. Partly because this is done by agar dilution. There is some use of gradient diffusion tests like e-test strips or discs, but you have to have a special media. It's a gonococcal test agar that has a 1% defined growth media. It's super specialized media. We discussed using other types of media last week when we had our case, because Nashville was affected by the storm as well, and we couldn't get any our isolates sent out for testing. But ultimately, anytime you try to deviate and use different test media, your results are really suspect. And so it's not, even though you feel like you're doing the right thing, it's really not the right thing to do. So we did not. And because it's really isolated, most clinical labs just don't perform testing, but a lot of labs still do a nitrocephin test or a cephinase test. And so CLSI does have a recommendation to perform a beta-lactamase test, which can detect penicillin resistance in Neisseria gonorrhea, but it's not the primary resistance mechanism. And so honestly, I'm not totally sure why CLSI still has this recommendation. Because it really only detects plasmid resistance to penicillin. And the penicillins have not been used since the 1990s for Neisseria gonorrhea. And people, especially clinicians, can misinterpret these results to mean that it's susceptible to a narrow generation cephalosporin or an oral cephalosporin, but that's not what this result means. It means penicillin susceptibility or resistance, because only a positive tells you anything. So as we had this case, we kind of dug through, the different resistance mechanisms in Neisseria gonorrhea. And just to hammer this point home, there's a bunch of different ways they become resistant to the beta-lactams. The majority of them are mutations to either efflux genes or the penicillin binding protein targets. A very common resistance mechanism that we're very concerned about these days is an alteration to the PDP2 target, which is called a mosaic penicillin binding protein, and that leads to ceftriaxone and cefixime resistance, and that is not going to be detected by the cephinase test, nor are all of these other mutations. And really the only thing you're looking for is the presence of a TEM penicillinase, which is found on a plasmid, and that is what that cephinase test can detect, but nothing else. One thing that's super interesting is this TEM 135, which is found in Neisseria gonorrhea these days, is a single point mutation away from becoming an ESBL, which would be super scary because then we would have untreatable gonococcal infections. So something to keep an eye on. So if you look through, you peruse through the M100, there is a bunch of instances where we recommend use of the nitrocephin test. And I kind of wanted to highlight some of these because I think in most cases, they're not all that helpful. So Enterococcus species, there is a note in there about doing a cephinase test because there are some resistant isolates that have a beta-lactamase. These are exceedingly rare. I think the last time it was recorded was a single case in like 2015 in India. We just don't see these isolates anymore. Much more common for ampicillin resistance is mutation to that penicillin binding protein. There is a recommendation for Haemophilus. The incidence of overall resistance to ampicillin is about 20%. And of that 20%, anywhere between 20 and 40% is caused by a beta-lactamase that would be detected by that nitrocephin test. The rest is not. And so again, a lot of mutations to those penicillin binding proteins that would not be detected by this method. And we just looked at our data at Vanderbilt, and there's a pretty high proportion of isolates that are ampicillin resistant but beta-lactamase negative. And so when we do the beta-lactamase test, especially if you're not doing any follow-up susceptibility testing, you're telling the clinician, or at least a lot of them interpret that to mean this thing is going to be ampicillin susceptible, but that's not always the case. There's a bunch of recommendations for anaerobes, and it really sort of depends on the species as far as the incidence, but most infections are mixed and have a beta-lactamase producing isolate. Staph aureus, incidence of resistance for penicillin is over 90%. Almost all of them have a beta-lactamase test. And so there's really not a lot of value to doing this test. And then SOSA, which stands for Staphylococcus other than Staph aureus, similarly have a lot of resistance. And again, nearly all of that's due to a beta-lactamase, but because the resistance is so common, there's not a lot of value in doing this test, and most isolates are susceptible. So my kind of take home from this is that, doing the nitrocephin test, you have to be a little thoughtful about how people are going to interpret it. But in most cases, it probably is not all that helpful. And so a couple of other organisms from M45 have recommendations. And in all of these cases, if you detect the beta-lactamase, it means that it's going to be resistant to ampicillin or penicillin. But if that test is negative, it doesn't mean that it's susceptible. So a couple of options to think about is you could report it if it's positive only, or maybe you could report it with a comment saying this indicates, no beta-lactamase, but does not necessarily mean it's going to be susceptible. But I do think it's something worth thinking about a little bit. So here's an example, Haemophilus influenzae, where we had a respiratory isolate, the patient has pneumonia, and we just say the strain is positive for beta-lactamase, indicating resistance to ampicillin. But if it was the opposite, you would not necessarily say anything, or maybe not even report the result. Okay, so for our baby, we did not report those nitrocephin results because it was negative, and they did agar dilution for us at the Tennessee Department of Health, and it was a pretty susceptible isolate. And so baby actually did really, really well, and they discharged her home to her grandparents. And so it's kind of a good ending for this baby. Okay, so moving on, this is a 62-year-old guy with problems with his big toe for the last 20 days. I think you can see he has a pretty big problem with his big toe. He's diabetic, he has a peripheral neuropathy. And he said the morning he came in, his toe swelled up and got red. So they did blood cultures on him and they did wound cultures. And this grew Streptococcus aeruginosus. And so they did a debridement, which is, of course, the treatment in this case. Unfortunately, when they did an X-ray, it did show evidence of osteomyelitis. And so we were looking at this isolate, and they wanted susceptibility results because they're treating an osteo at this point. And we had a heck of a time getting this bug to grow on the blood Mueller-Hinton agar. And our QC was totally fine for our pneumococcus, no problem. And what was going on at this time is our lab wasn't able to get our blood Mueller-Hinton agar from our typical supplier. And so we swapped out to a new supplier. And for some reason, our strep anginosus just weren't growing on this alternative media. This is something, I've definitely seen in a fair number of studies, especially when you're dealing with more fastidious organisms, but not all Mueller-Hinton agar is equal. Technically, they all conform to a certain standard, but then also the blood Mueller-Hinton agar is not all equivalent. It kind of, and this may seem crazy, but it kind of depends on the age of the sheep's blood that's used for that. If the sheep's blood has been, in a bottle sitting in the fridge for a couple weeks before they use it to make the media, those red cells have lysed a little bit and the media is a little bit more rich. Whereas if it's, drawn straight out of the sheep and put in the media, those erythrocytes are super happy and maybe the media is not quite as enriched. So it's something that definitely can happen. And so, I don't even know, and I'm sure you all have the same scenario, but I feel like, for a while there, a good 90% of my job was just dealing with the supply chain issues. And, trying to figure out what to do in the middle of the pandemic was a little bit different, I would say, than what you would do kind of in normal times. But, to focus in a little bit about the susceptibility testing side of it. So we know that we have exempt microbiology media, right? And so that includes a lot of additional commercial QC that's done, and a lot of data went into studying these media to make sure that there's minimum lot to lot or manufacturer to manufacturer variability. So these are our exempt media. But as we know, not all media is exempt. So for example, our blood Mueller-Hinton agar is not. And as we're making these swaps, as we've just had to throughout the pandemic, additional review is probably warranted when you're just swapping out manufacturers and getting whatever you can into the lab. And so, this is really difficult, like I said, and probably what you would have done, 5 years ago, if you were switching major manufacturers of your culture media, would be totally different from how you approached it during this pandemic. I can remember we did, a multi-month validation when we switched culture media when I was at UCLA. And now it's just like, well, is it available and can they ship it to us? In which case we will use it, because it was so hard to deal with this. But I think the thing that makes the most sense is a risk-based approach to these types of things. And so, we put together, well, okay, I'll be honest, I put together what I was thinking about it for this talk, not in real time, but, I think it's helpful to think a little bit about the risks associated with swapping out media or gradient or discs through different manufacturers. And so these risks, include, of course, that the worst end is a false susceptible or false resistant result. And I think that the likelihood of that is pretty low. That there is that buffer zone between S and R, which is that intermediate category that can help us protect a little bit against that. But nonetheless, the impact would be if it's falsely susceptible, the patient fails therapy. If it's falsely resistant, the patient is escalated unnecessarily to a broader spectrum drug. And so, as we're thinking about this, like we did with our IQCPs, the types of mitigations you might have in place for those things is you really want to review that QC, and not just is it S or is it R, or is it in range or is it not in range, but what are your trends looking like? And when you switch media, did you see a giant, shift in your zone diameters or your MICs one way or the other? You want to also carefully review your results for every isolate. And this is something that I think it's hard to do in real time, but I really do think it's important. If it's worth doing a susceptibility test on an isolate, it's worth really carefully reviewing those results, like we've talked about throughout this talk, and then evaluate for trends. Other risks is you could have a shift in your MICs, and I think that's a pretty likely thing to have happen. What might happen here? Well, if you're at an institution where your pharmacists are really scrutinizing those MICs and adjusting the dosing, maybe they're going to adjust a little high, a little low, but I think that is a lower risk overall. And so what you might consider as a mitigation is just, letting your pharmacy and clinicians who do this type of thing know what you're kind of facing through this pandemic. And then the other risk that we actually experienced was our fastidious organisms just aren't growing on these alternative media. And this is a pretty low likelihood, although obviously it can happen. And the impact there is that you're not going to get a susceptibility result, and that may delay optimization of therapy. And one thing, to mitigate when you're getting these media in is you really want to test the growth of that agar or the media without any susceptibility tests on it. Particularly for some of the really susceptible isolates, the zone size around a disc can be so big that it looks like there's no growth on a smaller Petri dish. And just, to give some clarity to this, the extrapolated failure rate for susceptibility test media is really low. It's like 0.04% for Mueller-Hinton agar, and for blood Mueller-Hinton agar, it's 0.03. And that's from data from a bunch of sources. So these are just some examples of what could be done. So there are some properties of the media that we use that impact performance, and this has been evaluated really nicely by the group at UCAST. And really what they found is the pH, the agar depth, and the content of those divalent cations, as well as the thymidine, are what cause the biggest variability in the results. And so they did a nice little study where they took 90 zone diameters per agar. They used 18 different discs. And what they found across all these different media is that 95% of their results were within the QC range. And not only that, but, almost, depending on the media, almost 80% of them were within a single millimeter of that middle of the QC range, which is really tight, really. The drugs that are most likely to be affected are your trimethoprim sulfa, your aminoglycosides, and your fluoroquinolones. And so keeping an eye especially on those when you're doing your QC is something that is worth doing. And just to say too, CLSI, we design QC so it will work most of the time. And so your QC strains are not really the good canaries in the coal mine. They will tell you if there's something really wrong. But those nuances, it is not going to be caught by that QC strain. And so you do want to be reviewing your patient isolates as you do this. There is some guidance from CLSI about QC that you need to do when changing media. And so if you're using a new manufacturer, they say just do a day of QC, which is pretty straightforward, I think. For your media, do 5 days of QC. So this is kind of helpful guidance, and it also from a regulatory perspective helps you just kind of justify some of your thought process. The other thing to do, like I said, is review your QC data. And I know most of us don't do this routinely, but sometimes, especially when things are so volatile like they have been, it's worth kind of looking at your results over time. And so, some drugs, like I said, the aminoglycosides are a really good kind of target to look at because they do tend to be more sensitive to changes in media. And so you can see here, we're ticking along pretty good with our QC, and this is in millimeters, and in green is what's acceptable within range. And you can see we switched manufacturers here, and our results maybe trended down a little bit, but it looked like they had before we switched. But if you look at your Pseudomonas, that's where you really see the differences, where all of a sudden you're no longer at that kind of midline area of your QC range, but things have shifted up. And that would be an indication that something's a little bit different. And so when you're looking at your Pseudomonas and your gentamicin in this case, the things that could be causing this is that high concentration of divalent cations. And in the M100, there's really good examples of the types of problems with your media and what you would see happening with your QC strains. So if your zinc content is out, for example, your Pseudomonas imipenem QC is going to suffer, etc. So that can be something that's helpful troubleshooting, especially if you're looking at multiple QC results. There's a nice table in the M100. So this is what that looks like. You know, in our case, the aminoglycoside zones were too large, could be that cation content. And helpfully, CLSI says use a different media, but if you can't use a different media, you know, you might want to just keep an eye on those results, but also other results that are known to be impacted by that problem. So in this example, tetracycline, that same cation content too low can lead to smaller than normal tetracycline results. And so you might want to caveat those or suppress them or talk to your stewardship team or whatever you need to do in those cases. So, you know, we at CLSI, well, okay. So let me take a step back. So at Vanderbilt, all of this stuff really kind of provided us a lot of opportunities to really review how and when we're doing susceptibility testing. So a couple of things that we've really focused in on is, especially for these more fastidious organisms, like, do we really need to be doing as much testing as we were? And so a couple of examples of things that we switched up is we used to do susceptibility testing for every single Haemophilus on a respiratory specimen. And now we're doing it if it's you know, predominant, or using the Q score to suggest that it's a more likely pathogen in that culture. Another thing that we were doing is yeast susceptibility testing on every single fungal culture, including any genital yeast. We've cut that back quite a bit because it really isn't needed based on guidelines. Another thing, so this is like dealing with the pandemic, things that we can do. So the other thing is monitoring those QC results carefully when you switch media, looks for shifts, looks for trends. And then, you know, I do think some pragmatism is a value in these cases. I mean, I don't think that you want to just switch media out or switch discs out or gradient strips out or whatever without really doing anything. But I do think you don't want to nuance those MIC drifts versus, you know, a bigger shift in your performance, and really look for those bigger shifts as you do these types of things. So we go back to our case. We looked at data from JMI Labs that had done, they published nice data on susceptibility rates. This was strep anginosus group. They had 211 isolates from the blood from US hospitals. And what you can see is they're really stinking susceptible to most drugs, a little bit of penicillin resistance, and that's it. And in our actual patient case, you can see it was susceptible when we finally were able to get a result to penicillin, to vancomycin, to levo, ceftriaxone. The Clindo was resistant. And so, you know, the tricky thing with this case is osteomyelitis. Like at first, I kind of put up a bit of a stink about whether or not we should even test this isolate, but when you look at osteomyelitis cases due to strep anginosus, it's often associated with an abscess, like in this case, and often these patients develop a bacteremia. And the average duration you're going to treat these patients is for 10 weeks, and they often require a partial amputation. So even though I was kind of on the fence about the relative value of doing this testing, I do think that the fact that this patient was going to be treated for so long, and you know, the risks of a bacteremia or an amputation were high enough that it really did make sense that we help them target their therapy a little bit. All right, so that's kind of what I have. I know it was a bit of a whirlwind, but you know, my summary from all of this, I think, is that susceptibility testing can be pretty complicated, especially when you throw in ancillary testing like genotyping or phenotyping for resistance mechanisms. But I do think you can maximize the value of what you're doing if you're doing both, but only if you have protocols in place for how you're going to compare those genotype results with the phenotype and make sure that they make sense. And if they don't make sense, some protocol to troubleshoot. And, you know, I think we've all experienced, and, you know, knock on wood, it seems a lot better right now. You know, obtaining test materials has been very challenging, but there are pragmatic approaches to mixing and matching. But I do think, you know, keeping an eye on your QC, maybe doing a little bit more of it and scrutinizing it a little bit more than you might, other than saying, yes, it's in, or no, it's not in, could be helpful. So I'll stop there. You can email me if you are shy and don't want to ask a question. Otherwise, I am happy to take any questions people might have on the call.
Thank you, Dr. Humphries. Great presentation. Do we have any questions from the members?
Yeah, I have a question for Romney. That was fantastic, by the way. So just this morning, I had a conversation with my lab about how we couldn't get any Mueller-Hinton.
Oh, yeah.
Which is
So I spoke too soon.
Anyway, I'm curious, with all of the switching that we're doing, with your strep anginosus, were you able to get your usual media, and did you test it, and did it grow? And did you have any idea why your alternate media failed?
Yeah, so we don't have a good answer for why the alternative media failed. I suspect it had to do with those red cells. I've seen that happen before with even things as straightforward as coagulase negative staph or Enterococcus, or, there is some media to media variability in the ability to support growth. What we wound up doing is going to a third manufacturer, and that worked out for us. So, good times. I do think, the other thing just to comment on, I know there's like this desire, or like maybe an inclination, well, maybe I'll just do a disc on a blood agar plate or a chocolate agar plate, or, something just to get a result out. And I would caution against that. We did a pretty good study on Staph aureus, like nutritionally variant Staph aureus that didn't grow on Mueller-Hinton. And we said, well, let's put them on blood Mueller-Hinton. And what we found is that we weren't able to detect oxacillin resistance. They'd have MEK and they were totally susceptible because they just didn't grow. So just be, cautious if you're making major shifts to your media. So like if you can't get Mueller-Hinton, don't try to use some other media because it probably is not going to work out the way you want it to. And your antibiogram is your friend. So, you can point to that sometimes too for people if you can't get, these more esoteric bugs tested.
Hi, Romney, Marie-Claire, great to see you, and hi, and thanks for the talk. I had a question about Niceria gonorrhea resistance. Since we most often are doing a molecular test and are not getting an isolate, what do you see as kind of like the best path forward from essentially what would probably become molecular testing for resistance?
Yeah, it's a great question. So so the tricky thing with Neisseria gonorrhea is resistance is really multifactorial. Gonorrhea have these type 4 pili that they send out into the environment, and they snap up little bits of DNA from their environment, and then they incorporate that into their genome, and you get these like crazy mosaic penicillin binding proteins, which cause resistance, or resistance genes from a Haemophilus, or whatever it is. So it's really difficult to say, okay, resistance to drug X is due to mutation here, or this 1 or 2 or 10 genes, because often as soon as you say that, somebody will publish a study that says, well, wait a minute, we have a bunch of isolates over here that don't do that. They do this other thing. That being said, I think that there is a trend for Neisseria gonorrhea to not think about detecting resistance mechanisms, but detecting the absence of a resistance mechanism, and the most common resistance mechanisms as predictor for susceptibility. So I'll give you an example. For Neisseria gonorrhea, we did a study working with Jeff Klausner at UCLA, who's a big STI guy, looking at the gyrase A gene on our PCR positive gonorrhea. And so what we did is we would take the remnant DNA and we'd run this little real-time PCR with a high resolution melt assay to say, is it a wild type gyrase A gene or is it not wild type? And if it was wild type, we said use Cipro. Because that correlated really, really well with ciprofloxacin susceptibility. And they're finishing up an actual randomized controlled trial where they treat patients based on those types of results. So I think that's Jeff's done so much work, but it's a really good step in that genotypic type resistance detection. story. And there's a couple of different companies that I know of that are working on different RT-PCR kind of point of care devices that would do similar things, not just for fluoroquinolones, but other, beta-lactams as well. So I think it's coming. It is tricky. And I do think there'll be a lot of bumps on the road as we get there, as new resistance mechanisms are described or recognized as more prevalent. But there's a lot of people working on that.
Thanks. I also think that, well, hopefully there'll probably be, and it's not a rapid test, but more next generation sequencing techniques that will enable us to look at a wider array of resistance mechanisms than maybe just targeted. But obviously that's not probably going to give you an answer in a clinically relevant time frame, possibly.
Yeah, and I think the trick with those two is there's a lot of resistance mechanisms that they don't contribute much to resistance. And so trying to pull all those, multiple mutations that you might see together into some sort of MIC, I think takes like machine learning to figure that out. So, but I think it's something that people are working on for sure.
Any other questions for Dr. Humphries? Okay. Well, thank you, Dr. Humphries, for sharing tonight with your expertise. And we'll go ahead and close. In closing, though, I want to just remind everybody, please check your emails for the details on our April 6th meeting. Again, it'll be a virtual meeting, and it'll be with Lars Westblade, who was one of the last speakers we had in person before COVID, I remember. So we'll have more on that coming out. So with that, hope everybody enjoyed it, and thank you for calling in.
Thank you, Dr. Humphries.
Thank you.
Thank you.
Thanks, Romney.
Nice to see everybody.
Thank you. Great talk.
See you, Lisa.
Bye-bye.